This conference will now be recorded.
Okay, super. So AnCan is grateful to the following sponsors for making the recordings possible: Bayer, Foundation Medicine, Janssen, Myriad Genetics, Novartis, Telix, and Blue Earth Diagnostics. We are also very grateful for all the donors who help support at the end of the year or throughout the year with their financial support to keep the group moving. AnCan respectfully notes that it does not accept sponsored promotions. Any drugs, protocols, or devices that you hear about in our discussions are based solely on anecdotal experience or clinical evidence from published studies that we come across. AnCan cannot and does not provide medical advice. We encourage you to discuss anything you hear in these sessions with your own medical team. And Rick, you asked to speak, so go ahead.
Yeah, evening everybody, and just again to reiterate what Mark said, thank you to everybody who has made a donation. We really appreciate it. For those of you who are new, we only have a fundraising campaign once a year, so you won't have to put up with this for much longer. We're probably going to call it a day at the end of this week, but many of you have donated, and thank you so much for doing so. But if anybody is listening on the recording and getting a benefit from this, then we'd really appreciate it if you go to our donation page. I'll also put it in the chat so Colonel Boykin can include it when he posts everything and make a donation. About 40% comes from you, the participants, and the balance comes from sponsors. And we'll be working with the sponsors next month in San Francisco, along with Dr. Mark and Dr. John. Hopefully they might get to meet some of the sponsors too. I don't know if it fits in with their schedules, but it would be good. So the other thing is the survey is Dr. John is now working on the analysis, but his team hasn't actually started yet. Is that true, Dr. John? I see you put your microphone
on. Yes, but we are really on the very verge, so we have to close. We have to close for new surveys within the next couple of days.
Okay, you heard it from the horse's mouth. And we're at 458 responses across the board. And we'd like to get over 460. We'd love to get to 500, but I don't think that's going to happen in the next 2 days. But if you haven't filled out a survey and you are listening to this, I will also put all of that in the chat window. So with that, back to Dr. Mark, and I have a bunch of work to do in the chat window.
Okay, thank you, Rick. So the way we manage this is to first review the stories from new people, and we found we could use our time more efficiently if we go through a questionnaire that the team has put together, and it has helped us use our time wisely. So let's get started with David. David came to us through Stuart Jordan. And thank you, Stuart, for sending him our way. Let me share the information I have, David. Correct me if I have everything or anything wrong, and then we'll have you embellish and fill in the holes in the story, okay?
Sounds good.
Okay, so David's 66. He lives in Portland, Oregon. He's a retired medical journalist and was discovered to have a PSA of 8.9 on a physical exam. It went up from 3.5. The first doc wanted to do a transrectal biopsy without the MRI guidance. And luckily, he was smart enough to say nope and did the MRI, found a new doc, and he had 3 lesions. They were biopsied, and you had 15 cores that were done. and you had a 4+3, a 3+3, and a 3+4. Was it just those three that were positive?
No, altogether they did 15 cores. There were 6 that were benign, 5 that were 3+3, 3 that were 3+4, and 1 that was 4+3 with cribriform.
Okay, and do you know the percentage of 4 in that biopsy that was 4+3?
Yeah, it was, let's see, I'll just read it. It says 4 plus 3 equals 7, 70% pattern 4, and involving 50% of tissue. And it says 4 of 5 core fragments, 15 millimeters of 32 millimeters total.
Okay. And they did not describe whether it was large cribriform or small cribriform.
Correct.
Okay.
The only other information, and this was true for all 15 cores, was perineural invasion not identified.
Okay. And so far you have not seen, have you gone to the radiation oncologist? You had said that you weren't interested in surgery and that you were going to try to get a PET scan. What have you learned since we all spoke before?
Okay, today was action packed. I saw my urologist this morning and we went over those results. And also, I did make an appointment for a PET scan next Monday. So
Great.
that'll be happening then, and I'm supposed to get the results within 48 hours. So I'll know a lot more then. The urologist.
All right there. Thank you. See if I've got my.
Someone needs to mute themselves because we're hearing a lot of background sounds.
The urologist went over the results this morning, basically, which consisted of him running those numbers through the Sloan Kettering nomogram, and so I saw what those are, and he made a case for surgery. I made a case for radiation, and I asked him for referrals, not to surgeons, because that's what he wanted to do, but to OHSU here in Portland. The big medical facility is Oregon Health Sciences University / Knight Cancer Institute. So I asked for a referral there, and I told him I was also going to check out UCLA, and so I will be doing that as well. And that's as far as it got today.
Okay, so just a few comments on the pathology. The single 4+3 means that you have Gleason 4+3 disease. We're only as good as the most aggressive lesion. And the old criteria where we looked at NCCN guidelines had a cutoff of 20% 4, so 70% 4 puts you in a higher group. Now, interestingly, Dr. Epstein this weekend was talking about the size being less a factor in terms of the lesion on the biopsy, and that the size on the MRI is probably a significant predictor of disease, but so is the cribriform pattern. And with that, there are a number of different types of cribriform. And there's a fellow, Jesse McKinney, at Cleveland Clinic, who has published on different types of cribriform patterns. And when the chunk of cribriform looking tissue, which is like Swiss cheese, is bigger, more than twice the size of the surrounding benign glands, they call that large cribriform. And that's the one that's supposed to correlate with more aggressive disease. Now, the problem with the cribriform and intraductal and any of these other things that we look at when we have a piece of tissue in hand is one, we're dependent upon the initial reading, whether that was done correctly. And then two, it's telling us how something behaves. It doesn't pinpoint what we should do now that we know that there's cribriform there. So if this is truly large cribriform, that does mean more points to more aggressive disease. If it's small, I'm not clear that it has any adverse outcomes. But again, that doesn't tell us what you might do and what might be best. I think at this point it does say that it's probably not a good idea to sit around and take 6 months deciding
Right.
what to do, and this is not a situation where you would consider active surveillance.
Or focal.
Yeah, or focal, definitely. So, anybody have comments? Actually, let's start with you, David, whether you have any questions for the group.
Well, I should also add the other thing that happened today is I asked my urologist to send my biopsy samples to Mingju, and Stuart was kind enough to provide me with that information, and also to Johns Hopkins. So it's going to both places just to get another opinion, because I had only really discovered this group on YouTube very recently. So I was unaware that you really needed a kind of a pathological urological specialist or prostate specialist to assess these. And so when we got the results, my wife looked up who the two pathologists were who looked at it, and one of them, and they were just with a local company that does pathology reports. One of them had no listed specialty, and the other one's specialty was breast cancer. So I'm operating on the assumption that the results are correct. That's how I'm going forward. But I am also sending those off to see what those two folks had to say. And I, I think my urologist thought that was overkill. But he said, he usually finds that the prostates he removes from people match up with the biopsies. But I know I've read in research studies that the biopsy is often not in sync with the um, extracted gland in terms of the cancer involved. It can be by 30, 40% sometimes. So who knows? But that's what I've done just to move this along. But so after the PET scan, my urologist, by the way, is just a community urologist, not even at OHSU. I found the guy I'm using now, just because I needed somebody to do a transperineal biopsy instead of their transrectal one, and I was kind of scrambling to do that. And but he suggested, after the PSA, that treatment in terms of the um, hormone therapy could start pretty much immediately to kind of freeze the cancer in place while I look around for a radiation oncologist to do the actual treatment. And that's one of the questions I have for this group is, does the timing of when the hormone therapy begins, how does that correlate with when the radiation should be done? Are they done one before the other simultaneously, or does it not matter?
Well, my reading on that has been all over the place. I know mine started a month before, but since then I've seen things that say that it probably doesn't matter. So I just wanted to mention that on the top line over to the left side, there is a box with a hand up, and you can, I think that everybody sees that there are people in line. And on the bottom, there's a hand up and it says react, and you can click on there. And that way we'll go through the people who want to make comments on this. Dr. Epstein again mentioned about 20% of the time. Not just that there's a difference in pathology, but there's a difference in the planned treatment protocol based on rereading the biopsies by a special pathologist. So I think it's a good idea to get that. Let's see, Stuart, I think you had your hand up first.
Yeah, David, they send a sample for Decipher test?
No, My urologist this morning kind of bristled at that and said, "Hey, you've got Cribriform. You don't need the Decipher test. We're going, you're going to need the ADT and treatment. So what's the point of the Decipher test?" And I was, and and he also said, "You're already sending the sample out to two experts. Now you want to send, it out to, there won't be any." He basically made it sound like you're going to run out of sample if we send it out to this many people. So what's the real story there?
Well, I think one of the things that the Decipher will do, there's a new test called Decipher Grid that is great for research, and every page on the 7-page report tells you this is not for clinical treatment, it's for research. But they are looking at quite a bit different um, criteria. They are not looking at simply the appearance, but they're also looking at genetic biomarkers that could predict aggressiveness. Now, again, it's not likely that it's going to affect your treatment outcome. But one thing they also will do is notice whether there's any genetic germline mutations. And specifically, I think they're looking for BRCA. Rick has posted the PROMISE germline study where you can get a free germline genetic screen, and it's worth looking through on that and signing up for that.
I've already done that. I did that over the weekend, learned that from this group. And the other one I haven't signed up for yet or applied for yet is the ProstDocs exam. So those are two in the offing, but the reason I guess I was also okay with holding off on Decipher, Stuart, is that um, one of the experts I'd like to see at OHSU Knight Cancer Institute is a genetic person, and just hold off and see what she has to say, because I've actually I know she's very good, and so just for lack of I'd like to go. I don't know what else to do other than just wait till I see her and decide what genetic test beyond the promise one I might need. Do you think anybody think I should just go ahead and do the Decipher one right now?
And Mark,
Oh.
the reason
Yes.
I asked is given the fact that if you've got 4+3, is the ADT a given or is that still a question mark?
Well, I would think it's a given with 70%. And the reading, if you confirm that, I certainly think it's a given. The question comes down, is it a 6-month given, or do they find something that says be more aggressive? There's a ton of information, and I think the problem with the new Decipher Grid report, which is far more extensive than the 1 or 2-page report you normally get, is that most of the oncologists, urologic oncologists, and certainly us patients are not going to know how to interpret that. Jim Marshall.
Yes, Dave. Before you do the ADT, make sure that you get a testosterone baseline established.
Thank you.
Okay, so at the time you stop, then you will know approximately how much it will. That's
Get a testosterone baseline. Okay. Anything else that I should do prior to that? I mean, I'm sort of hoping I can line up an expert on that topic as well, maybe a medical oncologist at OHSU, to walk me through that rather than just rely on my community urologist. Do you think that's necessary? That would be helpful?
I think the going to a medical oncologist usually is reserved for more aggressive disease. So if the disease were outside the gland or there was evidence of metastasis from the PET scan, then I think you'd certainly want to get that opinion. Most ROs, radiation oncologists, are going to be able to manage at this stage or your next stage. I'm not sure that urologists will have a lot to offer between here and your next phase. Talking you away from some of the things that you've said does cause some concern. Sandy, you're up.
Yes, good evening, everybody. Actually, let me make a comment regarding second opinions. That was one thing I wanted to discuss with you all. My urologist sent my slides to John Hopkins, and I got a...
Hold on, Andy.
Andy, we're going to stick and finish with this and then hear from the other new person, and then we'll come down. Do you want to comment, David, about his situation?
Do you have a comment for David on what we're talking about?
Yes, David. I got a second opinion, and it was a 3+4 on two of them initially. John Hopkins downgraded to a 3.3 on one of them. So my second opinion was quite useful, and I'm probably going to get a third from Ming Joe if needed. Talk to you later. I'll yield to the others now.
Let me ask you a follow-up on that. So is that covered by Medicare? And does Medicare cover more than one of these pathology second opinions?
Well, I certainly hope so. I have Medicare and I have a Health Net supplement, but the way it works, you don't get a bill showing they paid for a month or so. So fingers crossed, yeah.
Okay.
My guess is they would not pay for a second opinion on that. I don't know if anybody who's done that has gotten.
I think you can get a second opinion on the slides, and Medicare will cover it. But usually, in the past, the cost hasn't been that great. Like $250, $300, somewhere in that region. Now, we do know that Dr. Epstein is back in business, probably in the month of February. There is an email to reach Dr. Epstein too. So now you have Dr. Zhou, who trained under Dr. Epstein. You have Dr. Epstein. So we have a wider choice, and so you can consider that, but it shouldn't be that expensive, and Medicare should cover the second opinion on the slides. Let me just add a couple of things to put your mind at ease, David.
Thank you.
So I was diagnosed many years ago, and I was 4+4, and I was T3. And I was diagnosed, I was tested in the May. I was actually diagnosed in the August. It was a 4+4 T3A. And my doc said to me, as long as you get treated within the next 4 or 5 months, it shouldn't be a problem. And there was no need to be thinking about starting hormone therapy. As it so happened, the treatment route that I chose required 28 months of hormone therapy, and I got my first shot in late November. But I'm telling you this because you have time. Most of the time, prostate cancer doesn't spread that quickly unless it's a real strange variant. And as long as we don't see anything outside, if the PSMA doesn't show anything outside, I think you will, if it were me, I would not be concerned about making the decision. Now, as far as the medical oncologist is concerned, I would say at this point, it's probably a little redundant. I would not be going, especially if I had a good RO. The other thing is that there is a distinct lack of good medical oncologists at OHSU right now. They've really been depleted. Sakharova is probably your best bet. There's a guy called Ung who's not bad. But the real good ones gone. They were really close to recruiting absolute top-notch person, but I think it's fallen by the wayside. Reason being that their GU group is in a total mess for a whole bunch of reasons, and it's very, very hard to get referrals from one area to another area. We've encountered a lot of issues at OHSU over the last 18 months. Since Tom Beer left, it's not been great. And they've lost good people like Julie Graff and Vuki and Jacqueline Vuki, and so that's where we are.
Rick,
That's
David has said that there is a MRI LINAC in town at a community center. Do you know if any of those people you thought were favorable have moved over to that other center in Portland?
No, Vuki and Graff have both went initially to Kaiser. I think Vuki's still with Kaiser. Graff is mostly with the VA. She's a little bit with OHSU, but you can't get an appointment with her unless you're a vet. So it's not a pretty situation, and we've actually seen some horrible treatment, especially in kidney cancer, in the last 12 months. So
I wanted to ask you about, now I know Mark has made a very strong argument that the radiation treatment, I should just go to UCLA and see Dr. Kashan or go to somewhere else of that caliber. Nagar at Sloan Kettering, he mentioned as well. But in Portland, is there anybody you know of?
Yeah, I mean, no, I'm not as much of a proselyte as Mark is in terms of the type of treatment and what you should get. It might be a little bit better. Would I go all the way down to UCLA personally? I probably would not, unless it was convenient to go to Kishan or to go to Nagar. Might be a little bit better. I don't think it's going to be significantly better. I think that in your case, probably what I would be leaning towards would be, and I don't know the extent, but I'd certainly be discussing treatment to the gland, probably SBRT, and 24 or 25 sessions across the pelvic girdle, IMRT. Mark knows more about this than I do, but they're still having trouble fractionating the SBRT across the pelvic girdle. So they can do it, but it's a bit touch and go. I would say you could probably get that. You should be able to get that from OHSU. But I would go to OHSU for the radiation. And Mac Roach's approach for somebody like you, where you are high risk, would probably be just 2 SBRT treatments to the gland, and then IMRT across the pelvis to all of the lymph nodes. Would you be better going through Mark's? Maybe a little bit. I mean, we don't know for sure, but it might be a few less side effects, but it's hard to say because everybody's different. But would I put myself out to go to MSKCC or to go to UCLA? Personally, I would not. I mean, I got seeds to the gland and 24 treatments across my pelvis.
Rick, the thing about combination therapy, which is what you just described, is everything I read about it says that the urinary toxicity is high risk. And I'm just wondering if I could just get away with doing SBRT to the gland and ADT and calling it a day.
I wouldn't risk it. To me, if you're a high risk patient, which you probably are with 4+3 and Cribriform, I've seen too many high risk patients that skimp and then comes back. They skimp on the ADT, they skimp on the treatment, and it just ain't worth, to me, it ain't worth the risk. Now, I don't know how serious your Cribriform is, how much Cribriform there is there, what the size of it is, which, as Dr. Mark pointed out, is critical. But I would be talking to somebody like either Kishan or Roach at UCSF and seeing how much treatment they recommended, and I wouldn't be arguing with them. If they didn't think you needed the additional treatment, I'd go with it. If they said, yeah, even if one of them said yes, I would go. I'm not so concerned about the urinary. I don't think the urinary will be that bad. I had a little bit of urgency, not very much. I had a touch of radiation cystitis about 2 years later, which is very typical. It was about 2 years later. Turned out it was really nothing. My big issue has been more with my bowel, but I had a weak bowel going in. So I've had issues. And again, it's not major. And 17 years later, I'm the right side of the grass. And I'd rather be the right side of the grass dealing with a little bit of radiation proctitis and a dodgy bowel than 6 feet under, which I could easily have been because my disease was already outside of the gland. So those are my 2 cents. That's what I did, and that's what I would do. I would not skimp. I really wouldn't. But
Since you mentioned Mac Roach, he's a co-editor of a book called The Handbook of Evidence-Based Radiation Oncology, and the co-editor of that same book is here in Portland, a guy named Eric Hansen. Do you know anything about him?
Rick, you're muted.
What's that?
Rick,
yeah,
muted.
I've heard of him. I would start with Hansen, get an appointment with Hansen, and then you can get a second opinion. And I would start there, and it makes it easier. You know, you don't have to be running to the end of the earth to if you don't have to, and you like the guy and you get on and he treats you. God willing, you'll have the same outcome as I had, which is a durable remission. I was treated in 2000, started treatment in November of 2007. The radiation started in January of 2008.
What about HDR brachytherapy?
So it really depends on how much cancer you have.
Okay.
Because they prefer HDR to seeds if you have a lot of bulk. However, Mac's approach right now is neither type of brachy. He goes with SBRT because he thinks he gets the same results and it's much easier on the patient. So,
I meant, what about HDR brachytherapy monotherapy plus ADT? Because I'm still.
well, again, it really depends on what a really good top-notch RO says and reads on your risk.
That makes sense.
I mean, Mac is more aggressive in treatment than Kishan is. We've seen Kishan say, no, don't treat. And we've seen Mac, you could send the same patient to Mac and he would treat.
Mm-hmm.
Now, for me, I trust Mac because he was my doc and he got me a great result. Or he was one of my docs and he got me a great result. Mm-hmm. And from having been in this biz for 16 years now, in terms of working with patients, I tend to err to more aggressive treatment because we see too many guys in the advanced group, in the recurrent and advanced group, where the disease has come back because they didn't do what they needed to do in the first place. Mm-hmm. Then it makes it much more complicated. And then you're talking about, well, am I going to have to stay on ADT the rest of my life? and nobody wants to do that, you know, and we don't want to be having that discussion.
4 plus 3 plus Cribriform, is ADT enough, or do you also throw in Veraterone or something like that?
You won't. First of all, it's very hard to get doublet therapy unless you have identified metastasis, because it's not the NCCN protocol. There are a few docs who will do it, and if they can convince your insurance, but essentially it's not going to be offered to you. Do you need it? Probably not. So now the question is, how much ADT will they give you with Cribriform? How bad is the Cribriform? I mean, typically with 4 plus 3, they probably wouldn't want to get. You might get away with 9 months, but the real discussion is 9 months enough? Should I be going to 18 months? And these are the issues I would be raising with my doc, with my RO. I mean, Dr. John, what's your feeling on all of this?
Well, my 2 cents would go right in there with your 2 cents, Rick. I mean, we're going to have a lot more information very soon, because we're going to have a PET scan. We're going to have a closer look at the pathology and a better description of that Cribriform. And so we're going to know for sure about metastasis. And so in a week, we're probably going to have some really good information to sway this one way or the other. Mm-hmm. But based on everything we're hearing today, I would not try to minimize treatment either. I would try to maximize my treatment.
Okay.
Let's go on, and we have a couple other people who have their hands up. So Michael Williams.
Well, my comment would have been from something that was said quite far back about payment. I'm on Medicare. I do have a supplemental policy, though, but all my second opinion, reread of pathology, and even a third appointment that I went to with a different urologist, I didn't get any grief on payment. Now, have I defined out exactly what the secondary policy paid and what Medicare paid? No, but I got no pushback, and I was only separated by a few weeks, because when I went to the second hospital and group in urology, they immediately wanted to look at my slides and reread. So I got no pushback on that.
Okay, thank you. It's good to know.
Sandy, you had your hand up.
Yes, just to chime in further, David, mine, I believe, will be covered, no problem. But even if you have to pay out of pocket, Ming, Joe quoted me only $250 if my insurance would turn it down. So I wouldn't worry about it at all.
Okay. Any last questions, David?
Yeah. Let's see here. I'm just wondering, I mean, it sounds like you folks have been down this road that I'm just now on. At this phase of the process, is there anything else I should be doing? Is there anything, when you were at this stage, you wish you knew that you didn't know?
I think right now the reread on the path and the PET scan, for me, particularly the PET scan, would have been great, because I went down the path of TULSA-PRO. It was whole gland, but it's still essentially focal treatment, assuming that things were not involved. I think the important thing to get a number of opinions on is kind of what Rick said. Once you have that information, get reads on what people are thinking on the whole pelvis versus just prostate and tumor treatment, and that's going to be the decision. That and how long on ADT. The other stuff is just icing on the cake. Those are the big things: is how long on ADT, second agent, and do you do the whole pelvis? Okay, let's move on. We have Michael O'Rourke here. Let's see, Michael, wondered if I can ask you some questions to get started here. So how old are you now?
74.
Okay, and how was your diagnosis made?
About a year ago, my primary care physician found my prostate enlarged to the point of his concern, suggested I see a urologist, which I did, and at Walter Reed, and she referred me to another urologist who did a biopsy, or he was a surgeon and did a biopsy, and then I was found to have uh, prostate cancer, and it was removed. I was diagnosed, I guess, in July, the end of July, as a result of the anyhow, and I was removed on September 5th.
So that was a prostatectomy?
Prostatectomy, right.
Okay, and did they do a MRI before the biopsy?
I seem to recall, yes, they did.
Okay.
I think.
Okay. And do you have questions for us here? Are you on any medication or has your PSA remained low?
I'm on no medication.
And how are you doing after surgery?
I think I'm doing well. I don't know what to gauge it by. I mean, I used to run a couple of miles a day before, and it's taken me now. I can run half a mile or walk 2 miles a day. But I mean, I think I think I'm where I should be for age and everything else.
I think the biggest concerns that most people are talking about would either be erectile dysfunction, which is not uncommon at our age anyway, and then also urinary incontinence. Those would be the two main things that we might experience.
Well, I had erectile dysfunction long before before I had my prostate removed. I was first diagnosed with it in my early 50s, and so my expectations in that regard are low. But
Okay.
you know the other part seems to be doing okay. I mean, the incontinence, it started like a stream, and it gets a little better every day. I've since changed from the pull up male diapers to now I'm just wearing a protective pad in my underwear, and that lasts all day. And you have one during the night, and so the incontinence is still there, but it seems to get better gradually. And I understand that from a support group I'm in, it could be anywhere from 3 months to 12. And so I was hoping for 3, but I'll take it when I can get it. And it's not that big a deal now that the cancer's gone.
Yeah. And what about the PSAs post-op? How often are you getting them and what have they been?
I don't have those with me. I've had it.
Okay.
I think I had a 30, a 60, a 90, and next I'm going to have 120. No, wait a minute. My next one's in March, and then after that I'll have something up before September. So it was 30, 60, 90, and then 120. And so I think that's all I think I've got scheduled right now.
So it sounds like you're in pretty good shape. Do you have any comments or questions for the group that they may chime in?
Not really. No, I belong to a support group through Walter Reed, and I met Jim Marshall on that, and he was helping me on my VA submission yesterday, and said I might be interested in coming tonight, and I am. I've learned a lot, and I just don't have many questions to ask because I think from follow-ups with my doc and everything, things are going to where they're supposed to be going, and so I don't have much. It's not that I'm not concerned, but I don't have much to worry about in that regard. I'm not worried about it.
Jim, you may be interested in hearing this. My next door neighbor is soon to be the new chair of the board of disabled vets. So I'm hoping to tie him into our group because he has access to all the political stuff to get things covered and help get through some of the smoke and roadblocks they try to put up to get the care you want. Jim, you had your hand up.
Yeah. the reason why I suggested him here because I heard that he had a Gleason score of a 4.3. Besides that, and a Cribriform. So I didn't know how
It's
the
4.5, Jim. It was 4.5.
Oh, a 4.5. Excuse me, plus Cribriform. So that's what sort of perked up my ears, and I suggested he might come here. And what does the
Yeah,
group think
Jim,
about
the
that?
thing is that unless he has to keep a very close eye, Michael has to keep a real close eye on that PSA, which he's doing. And
Okay.
and Michael, I'm assuming your PSA has been undetectable. It's not come back with anything more. It's been less than 0.1 every time, correct?
It's been less than 0.00.
Perfect. So
Okay.
as long as it's less than 0.00, we don't have to worry about additional treatment. Now,
Okay.
if it started to climb, yes, we would be very concerned and we would jump in. But there's no, even if he's a 4+5 um, and he's and he has Cribriform, it doesn't matter if he's had a successful surgery, which sounds like he has. Was the
Okay.
4+5? Was that what was confirmed on your pathology after the surgery, Michael?
I'm looking. Yeah, it's October 21st. There's a date on it. Yes,
And that's after the surgery, correct?
right.
Yeah. So, yeah, I mean, you'd be doing fantastic if you continue the way you're doing. If you would have come in here ahead of time and told us, we probably wouldn't have thought that surgery was a great idea, but you're doing great. God bless you. And just whatever you're doing, keep doing. Have you changed your diet? Sounds like you're doing the exercise. Have you changed your diet at all or not?
I didn't have to change it much because it was pretty good before I started.
Oh, yeah, with a name like Michael O'Rourke, I figured, there'd be plenty of boiled beef and carrots in there, and
No, 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 no alcohol, no tobacco.
oh
Cut
my
the
God.
fat out. Have 1 cup of coffee a day. I'd like to have about 9, but have 1 cup of coffee a
Oh,
day, and that's it.
coffee's not so bad. You're fine with coffee. We think it's yeah. Well, wait a minute. I If we're going to talk about coffee, we have to ask Dr. John because he is our resident coffee expert in many different ways. And before I hand it over to Dr. John, I just want to make sure: do we have email addresses from Michael and from David? So that we can send you reminders. Are you signed up?
Michael, yes.
Did sign up for the newsletter, yes.
Okay,
Thank,
great.
thanks,
Okay.
Jim. Yeah.
Dr. John, you are the coffee connoisseur around here. And
I
what's
think
your take on coffee and cancer?
I think you're fine drinking all the coffee you want as long as the way you administer it the way I do, which is orally, and not the way that Rick promotes, which is rectally.
Oh boy.
Uh,
Oh
Yeah,
boy.
drink up.
I
Don't
thought you
worry
were
about
coming up with something to do with the leftover grounds. You know,
that.
There's an awful lot of literature on whether coffee is beneficial and prophylactic when it comes to cancer or not. By and large, and I think there was something in the most recent cancer. What's it called? This Cancer Today. There's something which I'm going to stick in the reminders. But by and large, I think coffee's fine if you keep it to around 3 cups a day. Um, so, so you don't have to ration yourself on the coffee, Mr. O'Rourke.
Thank you, Rick.
Jim, did you have your hand up again? No. Okay. Michael, was your margins clean when they did this?
Yes.
So one of the, I mean, it's across the board when they look at adjuvant treatment. There's discussion and controversy when you get more advanced high-risk disease. Do you do radiation right away or do you wait till later? Now, the problem that I think that I see most of the data looking at large groups of men find there is no benefit from doing the radiation right away. The problem is that we are so different. No two of us have exactly the same cancer, the same cells growing, and no two cells, maybe two, but all the cells in our cancer don't all behave the same. So one of the advantages of something like the Decipher Grid, which we talked about before, is going to enable us to complete studies that will say, well, across the board, it doesn't make sense to do radiation after surgery, but if you have this, this, and this, it may make sense. We don't know that now. And the same with ADT. I haven't seen anything definitive, but I've seen that people are looking at certain situations where ADT might be useful after surgery as well. I mean, that opens up the question about studies that look at radiation. If someone starts out with surgery and they need radiation after the surgery, are they taken out of the study, or are they considered radiation people, or are they considered surgery people? It's somewhat confusing, and I don't think we have the final answers on that. So I think let's move on to Sherelle. You are up now.
Hello, good evening, gentlemen. Just want to come back to this group. I have a consultation with a radiation oncologist at UAB on Friday, and I just would like to hear from this group what are the questions that I need to ask on Friday.
Can you fill us in briefly about the stage of your tumor and how it was diagnosed?
Yes, it was diagnosed through a transrectal biopsy back in October.
And I forgot what you had said previously. The Gleason score was.
Yeah, 3+4 marks.
Okay. Do you know the percentage of 4 in the in the treatment?
I do not.
Okay. So my understanding with most 3+4, if there's high volume and you had more than 50% of the cores positive, or a high volume of the percent 4 above 20%, they used to think that would make it was more aggressive disease, and they would call it intermediate unfavorable. But I would certainly ask, do you consider my disease an intermediate risk favorable or intermediate risk unfavorable? And the main difference there is if it is considered unfavorable, most radiation oncologists are going to recommend the addition of ADT, which would either be an injection like Lupron, Eligard, or something like that, or Firmagon, or pills, Orgovyx, which are somewhat advantageous because if you just can't tolerate the ADT, you can stop Orgovyx and it's cleared from the body quicker than the injectable medicines. I think it's going to be pretty straightforward. I'd ask how many treatments, and if you're a good candidate for SBRT, most radiation oncologists will treat for just 5 sessions. If it's low volume disease, they're not going to want to treat the pelvic lymph nodes, and they'll just treat the area around the prostate. But you want to know that there's enough disease that it warrants treatment. And a Decipher score, if you have favorable disease and only one positive core, and the Decipher score is low, it may be that you're a candidate for active surveillance and wouldn't need to go into treatment right away. So those are the things that you want to ask. Am I a candidate for active surveillance? What makes this disease require treatment? Why would you not? If you don't treat it and I go into active surveillance, are you going to manage it, or will someone else? Those are kind of questions. Anybody else have comments for Sherelle? Sandy, go ahead.
Yeah, Sherelle, I met with a radiation oncologist last week, and I have a very similar situation to you. One, 3+4 with 15%, I believe. He indicated I'm a candidate for brachy, which are the radioactive seeds. However, I guess due to the size, I would need a PVB or green light laser prostatectomy before he could treat me, because apparently the radiation seeds cause swelling. I don't know if the external, you have the same problem, but just FYI, that was one of the things he told me. I have to wait and see my urologist for that.
Sandy, was it only one core that's positive?
Well, initially it was one core that was positive at a 3-4 and another one, but the John Hopkins downgraded the other one to 3+3. So I have 2 3+3s and 1 3+4. Again, he said I could probably actively surveil, but not a good idea with that particular 3+4. I should be treated. So we're kind of in a similar boat, Sherelle. But I would ask him about, if you need some treatment because of the swelling, you wouldn't be able to urinate. That was kind of what was indicated to me with the radiation.
Thank you, Sandy.
I'm not sure I understand that, because I had an enlarged prostate and went through the 5 treatments with SBRT and, didn't have that problem. I think that it might not be a bad idea to listen to Rick when he tells you how to get in touch with the active surveillance group, because I think it sounds perhaps aggressive to have to go through 2 procedures and 2 anesthesias, once to treat the prostate, and then to come back months later to have the cancer treated, when active surveillance should be enough. Now, if you're already having extensive problems voiding now, then you might benefit from that. But, you could also do something like TULSA-PRO, which would improve the urination, shrink the prostate, and treat. But again, it kind of looks like it's unclear that you need treatment, and we can't say that here. We don't know everything about that 3+4 lesion that you have. Rick, go ahead.
Can we just stick with Sherelle and come back
Yeah.
to Sandy for the second?
Sure.
Sherelle, there's a couple of things that go through my mind. Did you say you don't know how many cores of 3+4 you have? Or you don't know the percentage?
I do not know the percentage, sir. It's two cores.
2 cores.
But I do not know the percentage.
Oh. So again, and 2 cores in total. Is that all you have, or do you have some 3+3s in there too?
2 cores total.
So I would grab your biopsy report and show up on Wednesday. Oh, there is no meeting this Wednesday. It's a 5th week. But before you make any decisions, both you and Sandy need to spend time with the active surveillance guys. And I'm going to turn this over to Jim Schrate momentarily because we want to basically scare the living daylights out of you for doing unnecessary treatment. We do not recommend treatment where it's not necessary. If it's necessary, we're the first ones to say so. David doesn't have a choice, but you guys have choice. Sherelle, you have choice. Sandy, you have choice. Notwithstanding, you've got doctors that want you to do procedures. You have a choice. And for people like you, we want you to be seeing healthcare providers who will encourage you to aggressively to look at active surveillance. Now, Counselor Schrate is a lawyer, not a healthcare provider, but he does a very good job making you aware of the risks. He'll tell you his story. I would also say that if minimal treatment is needed, then I would not like to see either of you, if you did opt for radiation, go through 25 or 26 sessions of IMRT. And that can happen very often because the doctors don't have the equipment. We also know, and Dr. John will pipe in on this momentarily after Jim, that you're much better off doing SBRT than you are doing IMRT because of some great research that Dr. John just did and we published and will be coming out in your next reminder. So I've spoken enough. Councillor Schrate, would you maybe talk to both gentlemen about the risks that they're going to be facing if they operate on these two small lesions, albeit they have 4 in them?
Yeah, I mean, my experience was that I had one positive biopsy core that was mostly 3, a little 4. It's been 15 years ago now, so I don't know the percentage or the length of the 4 in that core. And when I heard that result from the urologist, and I believe it was over the phone, I said, well, okay, that doesn't sound too bad. I'll see you in 6 months. And they said, not so fast. They said, because I was 58 years old at the time. I'm 73 now. At the time, they said, because you're young and because you've got 4 in there, we think you need treatment right now. I did some research. I read the wrong stuff. I read Pat Walsh's book cover to cover. And while there's a lot of information in there, there's a lot of misinformation about radical prostatectomy. And I ended up having a prostatectomy. And, the urinary continence has come along okay, but the sexual function has never come back. And it's not just erections, it's orgasms, it's leaking during sexual activity, it's shrinkage, it's low testosterone. I really regret having that treatment. I will till the day I die. So what I would suggest is you come and you hear about active surveillance, and you've heard a little bit tonight about the kind of workup that David is doing in terms of getting second opinions on your slides and getting second opinions on your treatment recommendations, and maybe getting a Decipher test. You need to do your homework and make this treatment decision carefully. It sounds from what little we've heard from both of you that you've got time to do this. You've got to sit back, you've got to do your homework, you've got to talk to some guys who've had treatment, you've got to talk to some guys who are in active surveillance and decide where you want to go with this. Because you've got time to figure it out, and whatever decision you make, If you have treatment, you're going to have to live with it for the rest of your life. And you need to talk to some guys that have been through it. And I'd be happy to talk with either of you individually if you like. And but come to the active surveillance group a week from Wednesday.
And before I got all this gray hair and retired here, I was a minimally invasive surgeon and did the type of surgery, not prostatectomies, but I did surgery. And the worst part about being a surgeon was in the healthiest people, you occasionally would have things that didn't go the way you want. You can have the best surgeon in the world. You may not have the best anatomy in the world. And there are differences in how everybody responds. And whenever you walk into an operating room, it's a serious risk. And there can be unforeseen things happening that may not be easy. So I want to make sure that, at least for myself, if I consider surgery, it's for something that needs to be done, and there aren't better or equally effective alternatives that come with far less risk.
Yeah, but not just surgery. I mean, there's a risk to any type of treatment.
Yes.
To any type of treatment, and we want to discourage people from getting radiation if they don't need it. That said, I'd love for Dr. John, because this will be very beneficial, not just for the people in the room, but for the people listening. I'd love for Dr. John just to say a few words about the research that we put into the reminder for our advanced group yesterday, because it's very pertinent for this group as well. John, would you like to just summarize it very briefly in simple terms for these guys?
Well, this is about radiation, nothing about surgery. But no matter what we do to our prostate cancer, whether it's ADT or testosterone blocking, immune therapy, no matter what, the cancer attempts to adapt to it. That adaptation basically comes down to resistance to treatment. Well, with radiation, the cancer cells have an opportunity to adapt to the damage done by radiation as well. The cancer cells that survive have been quite damaged, and they're very highly vulnerable to lots of instability in the DNA, which makes them able to mutate very actively. Well, it turns out that the way radiation adapts and becomes, the way prostate cancer cells adapt and become resistant to radiation actually is different depending on whether the radiation is administered 5 times in big doses or 40 times in small doses. There's an advantage to having fewer treatments at higher doses, because the kind of cancer that results from the adaptation is much more aggressive after the multiple low doses. So I think it's going to influence a trend, accelerate a trend that's already been going on for a few years toward breaking your radiation treatment into fewer and fewer treatments. Is that what you had in mind, Rick?
And I think, and this is particularly pertinent to some of you guys, if you are a good candidate for this, what we call hypofractionated or SBRT type of treatment with CyberKnife or Gamma Knife or whatever the commercial name is, and your doctor says, well, we don't do that, then you say, well, I need to get a second opinion. So what we don't want you to do is be pressured by your doctor to do the treatment that they're offering because they don't have the equipment that offers you the best treatment. And for gentlemen like Sandy or Sherelle, if they are going to choose radiation, and frankly, if it were me, I would probably be watching that situation closely on active surveillance for as long as I could. But if you're going to be treating, you definitely want to be doing SBRT. And if you don't have an RO that has that equipment, move on. That's the take home, I think, from what John has told you and what I've added. Ooh, somebody, David.
I just wanted to add on that, Rick, though. There is a group going on now, a test called the Prostox test, where some people believe, it's not fully vetted and validated yet, that certain genetic profiles increase our risk for long-term side effects after radiation. And if you're in the 7 to 10% that have this abnormal panel, they're recommending a slower schedule, notwithstanding balancing that against what was just said by John on the mutations that may result on the cells that survive the initial radiation treatment. Let's see here. David, you had your hand up. You're muted. David, you need to unmute.
I just had a quick follow-up question to what Rick just said. Earlier you were recommending combination therapy, but that's brachytherapy for the gland and IMRT for the rest of your pelvic area. Well, that is IMRT. That would be the slower approach, right? So how do you get around the problem you just mentioned about the mutation issue with IMRT?
What we're talking about at this point is treatment to the gland. We're talking about, I was actually saying SBRT, as Mac does 2 SBRT rather than brachy. So if you can do SBRT to the gland, do it. Now, what about across the pelvic girdle? The problem with the pelvic girdle is that we have technology right now that can fractionate this this more intense radiation machine, but it's not in common use, and probably Dr. Mark can speak more to that than I can. There are certain radiation oncologists who will give you SBRT to treat you across the pelvic girdle, but it's still, we're not really there yet with it, and we're not that comfortable with it. Mark, what are your comments on SBRT for when we're treating the pelvis as opposed to the gland?
So they're not definitive. I've not looked at enough that says one way or another, but I do know that certain machines just don't have as big a window with treating. So it may be harder to cover the large area that would be required to get the whole pelvis and to get a sufficient dose to the prostate. So I think that's going to be dependent upon, one, the equipment you have, and two, the experience that the radiation oncologist has. Obviously, along the sidewall with the bowel, you're more concerned about movement of the rectum and filling and what have you. So it's a bit more complicated. But I don't have a definitive answer there, Rick. Sandy, did we get you?
I just have a follow-up essentially to David's and your discussion. My oncologist, radiation oncologist, recommended brachy alone without ADT, without any SBRT or IMRT could cure not cure, but could take care of my issue. I have 1 3+4, that's it now. The other's a 3-3, and it says equal or to 5% Gleason pattern 4. The rest of it is grade 2. So active surveillance sounds like something I should look at, I'm concluding. Is that what you all concur with?
Absolutely. I think the Decipher score would be, also support that decision once you see that. But again, I always like to go to the PROTECT study. There isn't a single study that you're going to read that perfectly includes people just like you. But the PROTECT study look at people with confined disease and found that active surveillance, surgery, and radiation had about the same biological recurrence. So, yes, you probably could cure this with brachy, but you could cure it by doing push ups in the corner. And when you go on active surveillance, 50 to 60% are not going to require ultimate treatment. So then the thing that comes through a lot of people's head is, well, I'm on active surveillance and I failed. Oh my God, this is escaped. It's not like you do active surveillance and then you come in 3 months after or 6 months after your last ADT and find that your body is filled with cancer all over. You will have time to treat it, and treating the biochemical recurrences is often quite successful. Not cure, but at that stage, it's probably not a function of all of a sudden the disease spread. My understanding as I read is more that these cells are anywhere at any time,
Okay.
and we suppress them. Our body has a way to keep them in check and keep them dormant. If they come back, it's not a function of how we treated them initially and treated the prostate. It's just that whatever keeps them in check is no longer doing it.
Fair enough. How do I get a Decipher? Who do I ask? My urologist? A different type of oncologist? Or?
No, just the urologist should be able to
Okay.
order that for
All
you.
right.
And it's not right now, there's an advantage. The urologist would have to maybe do some studying to better understand it, but there's something called the Decipher Grid,
Right.
which is a more involved report. And you want to ask for that report and not just the routine Decipher score.
Okay, I won't dominate your time. Thank you. Been very, very helpful. I'm going to look in on the active surveillance as you guys suggest too.
That
Okay.
sounds super.
I'll mute out.
Stuart, you're up.
Yeah, I just have a quick question. I am 2 months post or radiation treatment and scheduled for my first PSA test next month. And I'm curious what other people have been told at that point as to what the expectation should be for the PSA after SBRT.
Well, your situation is complicated because it was like mine when I went in and I had radiation after the TULSA-PRO, and Keyshawn said, "Well, we did one other person before you." I mean, you're in this new study with the IRE to the dominant lesion, and then a lower dose of radiation to the rest of the prostate. So I'm not sure I would get very upset about a single reading on it. I think I might want to follow off and see a trend over time. Again, knowing that if you do this values 3 months apart, nothing horrible is going to happen. And I just want to see where the trend goes, knowing that you could have some bounces along the way as well. But I don't think what someone has done IMRT for 28 treatments really predicts what it ought to be in your situation.
Yeah.
Any other comments from anyone on that?
I would say that you can really take that to heart and do not worry about it if you don't see a drop right away. It might, who knows, it might take a really long time. Be patient.
John, I'm just curious, John, because you had a similar treatment in terms of the Dr. Nagar. Did he tell you anything about what your expectation should be?
No, I see him March 5th, so my endocrinologist wanted to do a PSA test Friday. I said, no, it's only 2 months. So I don't know anything. I'm in your boat, but I had 40 grays. You had 30, and you had IRE. So like Mark said, there's, who knows? I had
Okay.
yeah, so that's about it.
Thank you.
We'll find out, right?
Richard, you had your hand up?
Yes. Matter of fact, my commentary that I mentioned that I wanted to talk about is directly related to Stuart's comment. I had my SBRT in May, and then in October, I had my first PSA, and as I reported out the group, it was a 5.95. I was a bit anxious at the time, seeing such a high number, but the pre-radiation PSA was 11.7. Post-radiation, 6 months later, was the 5.95, and just recently here, in January 23rd, it dropped to 3.97. So it's showing a downward trend, and as you've just heard, that it's from everyone else here, it's all going in the right direction. And you also heard to be patient. That's something I have to certainly sink my teeth into also. But my question, I can ask this now, is at what point would it, what reading would be, to use Rick's term, durable remission? Why would that be 1.0 or less? I mean, is that the anxiety goes away below 1.0, or is it below 4, below 3, below 2? What? Any comments on that?
Well, normally they're saying 2 is the old Phoenix criteria. The advantage now is that PSA, at least in my opinion, is not the be all and end all. And regardless of what the PSA is, we should again go back to looking at it as the check engine light and not as definitive. We want to look at these tests and say, this is bad, or this means we have this, or this means we have that. And we have to rely more on imaging, potentially biopsies, circulating tumor cells, circulating tumor DNA. There's so many more ways to figure out what's going on inside our bodies, and PSA is probably the weakest one. But I think most urologists will pick a number 2. But I think it depends on where your nadir is. When you follow the levels down, when you reach nadir, and then is it starting to come up, or if it's stabilizing at a given number. So anybody else have comments on that? Do you have anything to add?
I mean, my only comment, Richard, is that you're really looking for stability and durability of your PSA level. And everybody's different, especially with radiation. When you have the prostate removed, it's a whole nother ball game, because we know there should be no prostate cells left in your body. So we know that you should be at less than 0.1. The problem is that with radiation, we don't exactly know how many healthy cells have been left. Now, when you do radiation with hormone therapy, the hormone therapy should drive you down to that level of less than 0.1. But when you don't do radiation, when you don't do ADT, we don't know where that level is. And in certain cases, we're going to see some sort of a bump because there's delayed inflammation that comes from the radiation, and that can cause the prostate tissue to aggravate, and we can see it rise before it falls. So what we're looking for over the long run, as far as I can see, is a stability in the number rather than an absolute number. And, if we see it dropping, and then we see it pop up again after about 15, 18 months for the bump and then come down again, great. But we can't say to you an absolute number. There isn't really an absolute number. I mean, the recurrence criteria is, if I remember correctly, 2 points above your nadir. So, but we don't know what your nadir is yet. Nadir means the lowest point, for those of you who aren't familiar with the terminology. Dr. John, did you want to say something?
Oh, no. No. Those nadirs are highly individualized, so
Thank you.
I don't
That
know yet.
was very helpful to hear. Thank you.
John, you had your hand up.
Yeah, I wanted. I've been on Avodart for 20 years now, since its introduction, 2002. So Dr. Nagar, well, for hair loss, believe it or not. So, Dr. Nagar wants me to stay on it. So, because I've been on it for so long, and plus there's some evidence that it does prevent prostate cancer growth, which I didn't even know until I started reading it in another forum. So, I mean, yeah, I guess it's the stability. As long as I stay at a certain level, doesn't rise. Once I hit nadir, then that's, so I have an extra issue with the Avodart. I'm going to stay on it, so I have no problem with it.
Okay, that sounds great. If there's nothing else, let's move on. Jeff, you're up next.
All right, cool. Well, typically I have a Monday meeting, and so it's hard for me to step in. It has been a while, and I did want to come in, and I'm the guy with the weird sort of treatment. Just real quick, like I went back and looked at some of my notes. So I was diagnosed back in 11/21. Got out of a healthcare system that had really no options for me. Because I have ulcerative colitis, they didn't want to do radiation at City of Hope, and we weren't really that excited about removing the prostate. And now I'm very happy I've moved away from that. Also, ulcerative colitis complicates some other things. So I was able, as some know, to get to UCLA and see Dr. Marks, who's really big on the focal therapies. And so we tried. We started off with cryotherapy back in. That was done in October of 22, and we didn't quite get it all. I had a cluster, and then I had like 3+4s, maybe 3 of them, and 3+3s. So really somewhat to the low grade, but we didn't really get everything we wanted on that cryo, and we opted for a whole gland ablation, which again, another relatively simple outpatient procedure. That one I did have some complications that I had to work through and had to self-cath for a while, but that settled down, and I've been really great for some time now. And so I've never had a problem getting up in the middle of the night and peeing. When I was having those complications, it was pads and catheter. It was rough, but it's been well over a year since I've had any of that stuff. So now on 7/24, my PSA was 1, and I'm on a 6-month deal. First it was 3 months, then 6 months, and I've had to push the actual visit back because I'm having an ablation probably on my back, but that's another story. But my PSA, which I just got last week, was 1.6. So in a low range. And I was kind of interested to hear how you guys feel about PSA numbers. And when I was last in to see Dr. Marks and I was at the 1, I go, so what's the number? What's your number? Because I don't really have a number. We'll know the number when we get to the number, if the numbers, jump real high. But that's kind of where I'm at. And I guess the reason why I want to take the time to report this is, I don't know, I think I dodged some bullets. and we like to say, I guess, no evidence of disease or whatever. I don't know. I'm always aware of what's happening. There are a few cancer groups I'm in. One that I really care for with my church, and they're going through a lot of different things. But I like the positivity. I like the encouragement, the opportunity to hear what others are going through, and my hope is that my journey, different from most, just another way of going about it. And any thoughts on that? And of course, my wife just came home, and so my dogs are barking like crazy. But let me shut that door. So I don't know. It's not focal therapies are not discussed a lot here, and so if there's any questions or any thoughts or anything for me, I mean, I feel like a normal human being. I don't pee a ton. I can go to an event and not have to go too crazy. So while there were some dark days in the journey, right now, for the moment, it is what it is. Any thoughts on that or questions or?
So my only thoughts would be that, we were just saying that PSA number doesn't count in your case. That's what you've got until we come up with a biomarker that is directed and validated to actually follow prostate cancer. We have some biomarkers that are pretty good for determining and predicting what might be the course, or predicting whether this is going to be aggressive disease or not, or whether you benefit from ADT or not. But in terms of monitoring post-treatment, we really don't have those biomarkers yet. So my thoughts are PSA might be the best thing that's available.
So when you say biomarkers, how does that? What is that actually?
Well, it could be a blood test. It could be a urine test. They may be. There's something called exosomes, where cancer cells shed off little bubbles of the inside surrounded by a membrane, and that floats in the blood, and they can get those out and measure what's going on inside the cells, looking for various markers from the tumor. And that's, or actually looking and counting the actual number of tumor cells floating around in our blood. And that may be a factor that will come to play in the future, but none of those tests have been validated where we can go in and say, tell me if I have any tumor cells in my blood. That was another interesting talk, and I forget whether this was as part of the active surveillance, but there was one person reported on a study with circulating tumor cells in people who came in for focal. They drew blood, and they ran, later on, they ran to see if there were any of these tumor cells that they detected in the bloodstream. And 75% of these people who were showing up for focal disease had other cells in the blood. So this is really beyond our understanding. Obviously, 75% of people don't have problems doing focal or doing any kind of treatment to the prostate gland. So we really don't know how to monitor this disease yet.
So and my understanding is it was explained to me when they do this total gland ablation, and ablation seems to be a deal. They do it on the heart. They might do it on my nerves in my back, but it's like an orange peel. Like they basically whole gland ablated. It's a urethra sparing whole gland ablation is what they call it. And so I guess really my question might be, when I do see Dr. Marks, is there a question I should ask him? I mean, it seemed to me like he's like, we're just going to monitor this, we're going to watch it, and I guess if something came up, they'd do an MRI. I mean, there's nothing really to biopsy, I don't think, at this point.
No, it doesn't go away, and I mean, we call it ablation, but even so, I would ablate uterine tumors, And even 6 months to a year later, they were 30 to 60% of the original size. When I was doing like TULSA-PRO and we saw that the temperature went up to all those cells and exposed them, they're still around. You still
Oh, it's
have
still
PSA.
there. It's not
Yeah,
gone. The
yeah,
grand
you still have
plan is still
PSA. You still have PSA, so you have prostate cells.
right. Okay. Right. Okay. So, is there a question that I should ask him, or just I'm just trying to be diligent. I feel like I've gotten out cheap, so to speak, so far.
I don't know cheap, but it sounds like you're in a great place.
Well, I am in a great place. When I say cheap, I haven't had to go through, the radiation, the other things, and
Yeah.
I guess I was fortunate to have low grade, and I think this is kind of like his thing, his specialty, and so for me, and I asked him because he's an old guy. I said, "How long are you going to continue to do this?" Because this guy's been around, and he just goes, because I get to see stuff like this. Like it's rewarding. Like maybe he's practicing medicine. Okay, cryo didn't work. We're gonna go do this, but then I have this result, and I'm not saying, hey, who knows what's gonna happen going forward, but I'll take my life right now. It's not bad.
Sounds great. Anybody have any comments for Jeff? Okay. Let's move on then, Mark. I know that you are new in the group. Thank you for checking in. Wondering if we might hear your story as to first, how old are you?
Thank you for letting me join, guys. I'm 56.
And where are you located?
New York City.
Okay. I don't think there are any cancer hospitals in New York at all, so you may need.
I'm out of luck, man.
Yeah, no, it's great. How are you diagnosed?
So my old primary care physician detected an uptick in my PSA in early 2023. And then I had a repeat, if I recall correctly, I had a repeat PSA test and then an MRI and then a biopsy. And at that point they found 3+3. I think it was 2 cores. I think it was 2 cores. I'm not sure. It might have been 1. And I was referred to doctors at NYU. I spoke with a surgeon and a radiation guy and an active surveillance guy, and I picked active surveillance. That was in 2023, and then last year, late spring, early summer, I guess, there was another uptick in my PSA, and my new primary care physician said, "Tell your urologist." And so I had another MRI and then another biopsy, which was in September. And so now I have 3 cores, 2 of which are 3+4, one of which is 3+3, and I was told I could continue to do active surveillance, but it wasn't recommended, and I should really choose. I should choose a treatment. And I left NYU. I've now gone over to Sloan Kettering. It's taken a while, I guess, because I thought for a while that I would talk to the doctors and the doctors would tell me, and I kind of didn't realize how much I needed to piece this together on my own. So that was, as I say, the second biopsy was in September. We're now into January. I've basically been told I'm pushing the limit of when I need to make a decision by, and I'm finding making a decision very hard for reasons that I don't, it's all the things that I hate about making a decision. It's an irrevocable decision, which has repercussions for my life and my enjoyment of life, and it's under a deadline. And I'm just finding making a decision very hard. And but I am leaning towards radiation. Okay, so I'm not sure which way to go with this. I can tell you the numbers of the biopsy.
Let me go back, and I have some questions that will at least
Okay.
help us figure out what's going on. What percent for was there in those two positive biopsies?
All right, so I'm going to go now look at my. Oh, I've been signed out. All right, so I'm going to go look at my test results. So there was one 3+4 pattern 4 approaches 50%, grade group 2 involving 70% of the tissue, 18 millimeters. One, which is 3+3, grade group 1 involving 25% of the tissue, 6 millimeters. One, which is 3+4, pattern 4 equals 10%, grade group 2 involving 25% of the tissue, 4 millimeters. I also have had a Decipher. I've had two actually, but anyway, here I am coming back to you. Okay.
Okay, now what does the Decipher show?
So the most recent Decipher. So, I forgot to mention, because you guys have talked about this, on the biopsy, there's a note, Cribriform pattern is identified. And for a while, I kind of was freaking out about that, but I've talked to the doctors, and they're like, at your stage, the Cribriform isn't, you don't need to worry about it for radiation. But I feel like it's one of those things that I sort of feel like I keep hearing different things, so it's hard to know. But anyway, to get to the question of the Decipher, what do you want to know?
What risk category did they put you in?
They put me just barely in intermediate. It is 0.46% on the Decipher score. Risk of metastasis with RT or RP is 0.08 for 5 years, 2% for 10 years. 15-year risk of prostate cancer mortality with RT or RP is 3.6%. And then the last thing I don't really understand, 22.7% at RP risk of adverse pathology. I'm not sure what that means.
So let me go over this. First of all, you're not alone. Most of us here have gone through that same period of time, confusion, finding that we're alone trying to make the decisions. You are not. That's what this group hopefully can do, is to provide you some peace that you're going along in the right direction and you're not walking on that alone. Rick just posted a discussion from Euro Today with Jesse McKinney, who really has looked at this. We used to say Cribriform pattern, and we'd freak and break out into a sweat. We now know that many people with Cribriform pattern have no increased risk at all.
If there's a guy on the Cancer Survivors Network who won't shut up about it.
Yeah, I know. And you're going to find that most places, because all these people who are on the internet are physicians. And if you attend enough sessions, we'll send you your own MD certificate that you can put up on the wall. But I think the first thing that one needs to do is to get an opinion from outside the institution on the slides and the reading. And either the pathology department at Johns Hopkins does this, or Dr. Ming Zhou, ZHOU, who's at Mount Sinai in pathology. And I think there are actually two Ming Zhou's at Mount Sinai. So you want to get the guy who's doing the prostate pathology to review the slides. And that would be a very first step to determine, is this small or what they call regular Cribriform, or is it large Cribriform, which means a big chunk of Swiss cheese like tissue, with these glands, and that whole section of tissue being larger than the normal glands that surround it. That's large. And if it is large, what that means is it could be a more aggressive cancer, and you don't want to ignore it. You don't want to do active surveillance if they see large cribriform. The other thing with this, the volume of 4 that you have in there is small. We also said earlier that Dr. Epstein, who really was, I think, in the forefront of stepping out and saying, you know, if you're reading prostates, you ought to read prostates. You don't read breasts in the morning and appendixes in the afternoon and other things. So he specializes in doing this. And he finds that 20% of the time, you change what you thought you would do or where you stood with the disease by getting that review from a specialist. So that's the very, very first thing that you need to do, is to figure out, you know, is it really 4 + 3, and is it large form? Sorry?
I'm sorry, it's 3 + 4.
3 + 4, yeah. Is it really 3 + 4? And is it large cribriform, and what percent? And we also posted Dr. Epstein's new email, and he's going to be starting sometime either in February or March. And I think he's going to be in New York City as well. So that's important. Now, you're lucky at MSK. I think Dr. Himanshu Nagar is great. He's a radiation oncologist. I'm not sure yet until you get that reading on the path, whether you need to rush off to treatment. So,
You
any
had-
questions?
Yeah, I was just going to say, Mark, it actually sounded like in one of those cores you had a fair amount of 4.
Yeah,
70%. So it's not a negligible amount of 4, but the concern that I have is that really 4, and is it and to what extent is it cribriform? And even if it was read at NYU or Memorial Sloan Kettering, I think you got to get either Epstein's eye on it or Joe's eye on it. And thanks a lot for Stuart. I was going to look for that. Stuart's put Joe's email in there, and they all know. Epstein and Joe know us here at AnCan very well. Epstein's on our advisory board. They'll both talk to you about it, and that discussion is very, very helpful. Anybody here had? Nobody here will have had a discussion with Epstein because he's been gone for the last 2 years. Has anybody had a discussion with Dr. Joe? Mark, have you had a discussion with Dr. Epstein about your pathology?
Yeah, I did initially.
Okay, well, it's very helpful, isn't it?
Yes, but that was before we knew about the differences between small and large.
Well, he knew about it. You didn't raise it, but he knew about it. But he's known this research for ages. It hasn't been something that patients have brought up. I think you'll find that Cribriform webinar, it's only 30 minutes long. McKinney was addressing patients as part of the group, so he makes it fairly easy to understand. And by the way, you don't have to cut and paste it. You can just click on it. It'll open in your browser, and you can look at it later. So you can watch it later. So that'll work. But yeah, well, you may need treatment, and if you do need treatment, then you got to decide who's the urologist you're seeing at MSKCC.
So I was told okay. Let me go back a second. The one of the cores has a pattern for approaching 50%.
Right.
I just want to. Yeah.
Yeah, no, I got it. I heard you.
And
so
my understanding is doesn't that put me on the border of being 4 + 3 if it goes over 50%? Or no, it doesn't
Yes,
work like
but
that.
yeah, but we got to make sure it was that's why we want to know from Epstein or Joe that they agree that 50% is approaching 50% is 4. It may not be.
Okay.
That's why we're saying to you, they may come back and say, oh, you are 4+3, and then we know you're going to get treated. So that's why we want you to send these slides off for a second opinion. Who's the who's the urologist at MSK?
So I was told that I had a urologist at NYU, but
Yes.
I don't particularly like him. When I went to Sloan Kettering, they
Yeah.
basically said, here's a surgeon, here's a radiation oncologist. I've also spoken with a brachytherapy doctor. I've also spoken with a focal therapy doctor, but I haven't been given just a urologist.
Okay, well, when I say a urologist, I guess I mean the surgeon. I suspect I know who the focal guy is, and we're not a big fan of his.
Is that Feinberg?
Who?
Feinberg?
No.
All right.
No, I was thinking of somebody else.
So the surgeon is Tugier. The radiation oncologist is Zachary Moore, who's very young.
Yeah.
But he seems to know his stuff. The brachytherapy doctor is Kohlmeyer.
Yeah.
The focal therapy guy was Feinberg, and let's not talk about that because I sort
Right.
of I
agree.
Okay.
Mark, both Stuart and John here were part of the RTIRE study. And once there's a final reading on the path, that might be something to look into as well. And you might want to hook up with Stuart and John to be able to discuss further your experiences with docs and what have you at MSK.
I'm sorry, I didn't really follow that. Could you say it again?
Stuart, who has his hand up here, and John S. in the group, both went through treatment as part of a study called RTIRE study, and that combines nanosurgery and radiation to the whole gland. If it's necessary, you might be a candidate, but they got to get, define what the path is.
So yeah, the options that were presented to me were radical prostatectomy, and the Tugier said that one of the lesions is near a nerve. He only anticipated maximum 80% nerve sparing on that nerve. The radiation more was suggesting the external beam with SBRT. But then I had been on the Inspire forum, and everyone there was talking about the MRI LINAC or LINAC, whatever that, And so I went back to him and I asked about that, and he said, yes, you could do our MR LINAC. He called it MR LINAC. You would be signing up for a clinical trial if you do that, because apparently it's new there, I guess. And I'm also
I would talk to. I don't know if you can move from one to another when you've already seen them, but the RTIRE study is using nanosurgery on the primary lesion and then treating the rest of the gland with the MRI LINAC machine. And I'm not sure that there's an advantage, but the thinking is that that's using a lower dose of radiation to the whole gland and might serve to better protect bladder and rectum. Side effects are still very low, but Stuart, can you share your experience doing that trial, please?
Mark, just first, I actually met and had a consult with Dr. Tugier also. And the two things in my research on him, one is he happens to be a very good surgeon,
Sure.
but he also was a doctor who, in my case, looked at my case and said, you don't need surgery. So, he got points for not insisting on doing something because he happens to be able to do it. That aside, I'm a little confused with the person who told you that MR Linac at MSK is just clinical trial, because John will tell you that he had that treatment separate from a trial. My trial is actually a Weill Cornell trial, and the IRE, the focal surgical portion was done at Weill Cornell, and then because Dr. Nagar moved to MSK, the patients then transfer over to him for that treatment, and we got 2 treatments as opposed to 4, just because they could do more in fewer sessions. But the purpose of my treatment was, the goal is to minimize, to reduce the risk of recurrence that comes from focal alone. I went through a bunch of conversations on focal, and focal alone, every one of them has incredibly high risk of recurrence. And I didn't want to do that twice.
And so is the nanosurgery focal? Is that what you're saying?
Yes.
Okay, nanosurgery is focal. I'd never heard that.
It's irreversible electroporation. They use electricity as the energy source, and in my case, they zapped about 25% of the prostate, because I had the area of interest was in one location, so they were able to treat the whole thing.
I mean, I've had 2 focal therapy guys, one at NYU and one at Sloan Kettering, say to me they didn't think I was a candidate for focal.
Well, I think based on where you said the location is, from what Dr. Tajir said, that probably that I would imagine that's why they're saying that. I'm biased because Dr. Nagar is my radiation oncologist. I would definitely talk to him to see what he says.
Boykin, you're up.
I'm sorry, say it again.
No, I'm saying I'm Boykin calling on Boykin Jordan.
Okay. Hey, Mark, I just wanted to offer, you was talking earlier about the difficulties of making decisions, being under you can't undo this decision, and you're gonna have to do it some lifetime things. So what popped out in my head that you may be interested in is joining the Men Speaking Freely, where folks talk about these mental type issues and dealing with that. And I think somebody's going to post it in the chat, but it's on the next one is on February the 6th.
Okay, I appreciate it. I'll check it out.
Right. And then the other thing I was going to say is sometimes you can get too much information, and you're better off instead of getting a bunch of conflicting opinions, is to try to figure out where the divergence is, where they start to come back together. And so you might want to think about how many different groups you're in and how many different other sources of information you have, because that makes it harder to make decisions, not easier.
Right. Yeah. Thank you. And it is. I mean, I have to say, jumping off on that, I wasn't thinking at this point that I was going to send these slides to somebody else to say, do I need treatment? It seems like everybody I've spoken to has said you need treatment at this point. I was just trying to choose a treatment.
Mark, here's the thing.
Yeah.
You may well need treatment. We're not saying send the slides to see if you need treatment or not. We're saying send the slides so we can see the degree of aggression of your slides, because if you're a 4+3 instead of a 3+4, it's going to make a difference. And I am not. I if I was in your shoes, I wouldn't be satisfied from the readings that I've had. I would get additional readings because a 4+3 is going to create different treatment alternatives to a 3+4. And that's why we're sending you, not because we think that you can continue doing active surveillance. Probably you can't, but I think you have to get a better handle on your slides. Stuart, what's on your mind?
I was just curious, since you went to MSK, did they request and read your slides? I know it's not the same as Dr. Zhao or Hopkins, but when I go, when I went to MSK, they wanted to see my slides.
I honestly don't know the answer to that. I haven't seen. I mean, I've had a PET scan. I do not know the answer to whether they've seen the slides. I assume so. I asked that NYU send over what there was to MSK.
We assume your PET scan was normal?
Yeah, my PET scan showed no evidence of spread to the lymph nodes.
So I mean that's the good news, but I just here's one difference. If you were to do radiation, then we have to get into the discussion, do we add hormone therapy? And if we add hormone therapy, how long for? And if you're a 3+4, the amount that we add is different to if you're a 4+3. Now, my own bias is that for what it's worth and the short time, you should add hormone therapy to radiation, because the side effects over a short period are pretty minimal for most guys. Not everybody, but for most guys. But on the other hand, there are some docs who don't think that that's the way to go. But for me, again, a little extra up front can go an awful long way. And that's why we really want to ascertain whether you're a 3+4 or a 4+3. We want to make sure that you do have Cribriform or not, and the degree of that Cribriform. And that's why we're saying get Zhao to look at this or Epstein to look at it.
Do you know how long that will take to get an answer back? Because as I say, I mean,
you have time. You have time.
The doctors that I'm talking
to have time.
Okay.
You have
Dr.
time.
Dr. Epstein says, Dr. Epstein says 2 or 3 day turnaround time once he starts doing this. Right. And usually, what is it, 7 to 10 days for Dr. Zhao?
Not long, but here's the thing: you're not even a 4+4. If you heard, maybe you weren't here when I said this, but I was a 4+4, and they gave me 4 months. So, right, and I was the same age as you, and my disease was outside the prostate.
I had the biopsy in September, though, and we're now up to.
But
January.
You're still only a 3+4. So you have plenty of time. I mean,
I was 10 months with disease outside the gland that had spread 10 months, and I'm now coming up on 5 years with undetectable PSAs after treatment. This is not a big deal. You have time, and the most important thing is you do not want to spend the next 40 years regretting rushing into a decision that really might not have been optimal, or that you didn't get the information you need. We're not talking about endless research and paralysis by analysis. We're saying a few simple pieces of information. You're already at a great institution where they have those things, but you got to clear away some of the the story about focal, clear away the surgery, which you're not going to do. So it's a fairly simple thing once you get a reading on the pathology.
I
The fact
don't.
that,
Yeah, go on. Go on.
I think it's a fairly simple decision once you confirm the pathology.
I want to go to Jim, but I also want to say one other thing to you, Mark. I go back a very, very long time with the Inspire Forum. And actually, in 2014, I got an award from Inspire for what I did on there. The problem with that Inspire Forum, and also with what we affectionately call Health Locked Out, Health Unlocked, there's a lot of experts who don't know what they're talking about and don't put weight on any opinion unless you know the person who it's coming from. It's so, so important. Don't rely on Health Unlocked. Don't rely on Inspire. What they're giving you is just that, opinions. Now, one of the things we pride ourselves here at AnCan is that we have really solid, really good information because the quality of our moderators are so good. And you're hearing stuff on this forum that is pretty indisputable. I mean, people will listen to us, that they're going to have a tough time picking holes in the technical stuff we talk about. We're not giving you the medical advice, but we're giving you the right technical information. Jim, why don't you talk to Mark?
Mark, I just hear the stress and the tension in your voice when you're talking, and this is one of the most difficult points in this whole process. I think you could talk to anybody here who would say that. You really you've got fairly limited disease. You've got really good treatment options, and you've got good docs in New York. I think, I know the biopsy was a while ago, but you do have time. And, the most important thing is you just take a deep breath, do your homework, think it through, and make the decision that you can live with for the rest of your life.
I have to say, I'm not clear on, okay, two things.
Okay.
First, I'm sorry, continue. I'm sorry, was there more you were saying?
No, I wanted to hear from you.
Two things. I'm honestly not clear on what I'm sending the slides to Dr. Zhao or Epstein to. It sounds like I'm just asking them to check the math of the doctors who have already said, here are your treatment options. The second thing was, I had questions to ask concerning, likelihood of recurrence, whether certain radiation techniques had advanced to the point where if there was recurrence, whether there could then be more radiation, or whether at that point, if focal therapy wasn't an option and there was recurrence, whether I would then have to move on to hormone therapy. That was really where my mind was. You may remember, Mark, when we were corresponding on the Inspire. So that's kind of where I was. And as Boykin was saying, it to a certain degree, you sort of get more information, and it can just be confusing. So,
well, my comments are that pretty much the same first line treatments. They're going to have the same recurrence risk, which will be fairly low with your disease. I think that the if it's a 4+3 and if there's a large Cribriform, then certainly they're going to want to consider the ADT. And the question of large versus small and how long to consider it, I don't think there's absolute evidence on that, but I do think that if there's signs of more aggressive disease, the ADT will be beneficial. With the MRI Linac machine that they're using at MSK, they can go back and treat about half the time. The lesion will be out of the field. Then some of the time it may be at the edge of the radiation field. Very rarely would the disease be in the same area that was already treated. Worst comes to worst, you can choose to do focal as a follow-up. One thing you will hear on the board, and this is an example of what Rick was saying about everybody has an opinion, and that is that, well, if you do radiation first, you can't do surgery later. There's no reason to look into surgery later at any point. Surgery at any point is going to have more significant side effects. And someone your age potentially could be facing 40 years of ED and incontinence. So, I mean, you have a great opportunity. The only reason I'm here is because I had cancer. And after I did my 5 days of treatment, I went out hiking, I went to museums. The worst problem I had with my treatment was getting on the 405 highway here. And cancer became boring. So now it's just an opportunity to get here and to let you know that this is going to be boring enough for you soon. And you want to take the time to do the right things now so you can turn this into a boring disease. Because for the majority of people, that's all it is. That's all it is a bore afterwards. And hopefully you'll continue in a group like this to help other guys feel more comfortable. I used to manage theater, and what I saw was the more people paid for their tickets in the theater, the more likely they were to give the performers a standing ovation. And I think that's the same thing that we see in prostate cancer, is those people who have reached that stage and done well are out there feeling like what they did was the best. And I mean, there's a little bit of truth to that. You want to know, you want to hear from people like Jim with his experience and the difficulties he's had. But it's important to go to the literature and see what the literature shows. And that's what the group here does. I mean, I've never met a general urologist who has spent as much time studying this as Rick has, and other people in the group, Dr. John. And you know, you're not in a horrible situation, and you have plenty of time to do this, and people wouldn't steer you wrong. You're 90% of the way to being done with this and for it to be boring for you. 90% of the way there to boring.
Okay. I mean, my doctors are telling me I don't have time. They're telling me I need to make a decision soon.
Well, again, that's because they may not be as experienced at reading the pathology and evaluating the Cribriform pattern. And they're not pathologists. And you need to get that voice from the pathologist rather than feel forced into making a decision prematurely. I wouldn't go to a pathologist and ask him about the surgery. I think it's important not to go to the surgeon and ask him about the pathology.
Mark, I think we've got to close up because people are dropping like flies and we're way over. Mark, do we have your email address, or have you signed up for a reminder?
I don't think so.
Okay. Would you like to receive a reminder for future meetings?
Sure.
Okay. If you want to put it in the chat window, you can send it to me directly or to Mark, and we'll sign you up. We'll also send you the reminder for speaking freely. These are really more than reminders; they're really newsletters because they have all kinds of interesting stuff in them.
I also want to apologize to Joe. I know you were hanging in there, and we didn't ask you. You got here a little bit later, whether you needed any time. If you did,
no problem. No, I'm fine. I'm just
great
today.
Okay, we'll get you in and come back in 2 weeks, and maybe some things will be resolved. But you know, I do think I don't think most docs would say to you that you have enough time to make a decision here. And I would just urge you to make sure. I mean, you don't want to be press ganged into a decision and then regret it later. And that's my concern. That's our concern here.
Okay. Mark, can I email you some about the questions regarding hormone therapy?
Sure,
Following
I'm glad to.
okay. Okay.
More than happy to chat with you. Okay, well, thank you all for coming in, and we will be back in the Actually, no, we won't. No, we won't. Rick, the next session is the week of ASCO.
Yes.
And my wife wants me to be all sorts of romantic, so I'm going to be in Carmel.
Oh.
On that Monday.
So you won't be here, but we will be here. We will. That's fine. Jim Schrate and myself, Dr. John, and maybe we can get Bill in. We will stand in for you as best as we can. So thank you for the heads up.
Sounds great. See you all.
Enjoy Carmel.
Thank you. I think we will. It'll be nice.
Okay.